I'm presenting a case of Biju Kumar, a 48-year-old gentleman hailing from Karakulam. He's a carpenter. So the presenting complaints were bilateral nasal obstruction for 2 years, a loss of smell on both nostrils for 2 years, mass per left nostril for 1.5 years, and swelling on the forehead for 3 months. Moving on to the history of present illness.
Anjana, one point. I think we will go with the basics, isn't it? Can you just scroll back? Can you just move back? Go to the first slide.
Yes, sir.
First slide.
Okay, sir. Sir.
Okay. I understand this is the epidemiological factors involved, isn't it?
Yes, sir.
Okay, tell me importance.
So,
just for the identification, or is it
important, sir?
Why?
Because each nasal masses, suppose if it is a juvenile angiofibroma, it will be more common in adolescent age group, and if it adenoids, it is more common among children.
You see, juvenile nasopharyngeal angiofibroma is a cliche because everyone knows about that, isn't it?
Yes.
Tell me another nasal lesion which is very common in adolescents.
Polyps and
fibrous dysplasia. Fibrous dysplasia is common in first and second decades of life.
Okay.
Agreed. Okay. Then we are just age. What is other other lesions which are specific for certain ages?
If it is an androconal polyp, because it will be more common in younger population, and ethmoidal polyp will be more common among elderly. And
agreed. Comparatively older, comparatively younger. Agreed.
Yes.
Then
and if it is an nasopharyngeal malignancy, it would be more common in 5th to 6th decades.
Okay. Malignancies in general comparatively common in older age.
Older population. Then inverted papilloma-like lesions, that's benign tumors, would be more common.
Okay,
from
middle age,
3rd to 5th
you
decade.
get more of benign tumors, and even your granulomatous illnesses are common in middle age. Agreed.
Yes, sir. Yes.
What about children?
Children, children, if malignancies, certain malignancies has got bimodal distribution, as in case of olfactory neuroblastoma, where it is more common in the 2nd decade and after the in the 5th decade also.
Since you brought up the topic, which other malignancy has bimodal age distribution?
One is olfactory neuroblastoma, sir, and
other one is, in fact, especially very common in Indian subjects. In fact, you mentioned that already.
Okay.
What about malignancy in nasopharynx?
Okay, so nasopharynx.
Malignancy in nasopharynx is commoner in Indian population and has a bimodal age distribution in Indian populations. Okay.
Okay, sir.
Second decade of life.
Okay.
Children, actually, you should talk about lesions like cystic fibrosis, first decade of life.
Okay.
Meningocele, encephalocele, even dermoid cyst, rhabdomyosarcoma. All these are childhood malignancies. Okay. Anything on that slide? Anything else on that slide? Since you are presenting this, anything else on that slide?
He's a carpenter, sir.
So importance?
Because this person has got more exposure to wood and he has got wood exposure, and so certain malignancies like sinonasal malignancies and nasopharyngeal carcinoma is more common in people working in wood industries.
Is it nasopharyngeal carcinoma or sinonasal malignancy?
Paranasal sinus malignancies and
so what type of wood is implicated in each malignancy?
There is softwood exposure and hardwood exposure. Adenocarcinoma is more common in softwood exposure, and
is it like that the other way around? Adenocarcinoma common in softwood or hardwood?
Okay, sir. Sorry, sir. It's the other way around.
Other way around. Okay.
Which sinuses? Which sinuses is more common?
Yeah.
Wood exposure.
Hardwood exposure causes adenocarcinoma of which sinuses? That's a question.
Oh.
Question. Nishant is asking. Adenocarcinoma. It is known as adenocarcinoma of ethmoids is known as woodworker's carcinoma. Okay, it is known as woodworker's carcinoma. Adenocarcinoma of ethmoid.
Okay, sir. Okay.
Have you inquired about the patient? Inquired about this to the patient, whether he is using hardwood or softwood? Do you know example of hardwood and softwood? Since you have written that, I just asked you just because you have written that. You
Yeah, okay, sir, I understand. Yes.
You have written carpet. That's fine.
Teak and mahogany are examples of hardwood, sir.
You asked it? Did you ask him?
Yes, he has got more exposure to hardwood.
Okay, good. Right.
Okay.
The duration also important. How long he has.
Okay, sir.
How long it is exposed is also important.
Okay, sir. Okay.
Other than geographical predictions, you have written what is it, Karabulam? Other than geographical predictions for any disease?
Rhinosporidium is a disease which has got a geographical predilection, sir. It is more common in people of India and Sri Lanka.
Okay.
And
any other disease? Rhinosporidium again is a cliche. Any other disease?
Sinonasal malignancies are more common among Chinese population.
Is it sinonasal or is it nasopharyngeal?
Chinese population, sinonasal malignancy.
No, it is nasopharyngeal malignancy. Okay. Southern Chinese population, nasopharyngeal malignancy, not sinonasal malignancy. Okay. Your rhinoscleroma is common in North India. Rhinoscleroma.
Okay, sir.
South India, it is much more common in North India. Okay.
Okay.
Right. Can move
on. The presenting complaints. He had complaints of bilateral nasal obstruction for 2 years, loss of smell perception for 2 years, mass per left nostril for 1.5 years, and swelling on the forehead for 3 months. Moving on to the history of present illness. Patient presented with complaints of nasal obstruction for the past 2 years. Has got obstruction more towards the left side than the right side. The nasal obstruction was insidious in onset, gradually progressive, which later became continuous in nature. There was no aggravating or relieving factors, and the nasal obstruction was associated with mouth breathing and snoring. There was associated hyponasal tone of voice.
What does it mean? Last sentence, what does it mean?
Because this patient has got mouth breathing and snoring, it means the mass is extending on to the pharynx, nasopharynx, and it's blocking the nasopharynx, and that is why he has got the mouth breathing and snoring.
It need not be nasopharynx, it can also be, agreed, nasopharyngeal obstruction.
Oropharynx.
Need not be oropharynx, it can also be mouth breathing, snoring, bilateral nasal obstruction. Okay.
Okay, sir. Okay.
Bilateral nasopharyngeal obstruction causes mouth breathing, snoring, and what else we written? Hyponasal voice. Very good.
Hyponasal tone.
What are the other manifestations of bilateral nasal obstruction? You rightly told mouth breathing, you told snoring. What goes along with that mouth breathing and snoring? There's a third component to that. Loud snoring. Ultimately, what happens?
Yes, the patient will get daytime sleepiness. Due to sleep disturbances. Obstruct. Yes, sir.
Okay. Again, dryness of oral cavity, oral dryness because of mouth breathing. Caries of teeth, dental caries. All these are very common. Okay. What is the most common cause of nasal obstruction?
In anatomy.
Actually, all going to basics. Okay.
Okay, sir.
We need to know basics especially when you are appearing for examinations, rather than going for high-fi things. That's why I'm asking you this. What's the most common cause of obstruction?
Anatomical variations.
Is it anatomy or something else? What about physiology?
Yeah, allergic rhinitis or.
I asked you what about physiology? Allergic rhinitis is not physiology; it is pathology, isn't it?
Nasal cycle.
Yeah, that's
normal
it.
Nasal cycles.
That's it. That's the most common cause. An exaggerated nasal cycle is the most common cause of nasal obstruction.
Okay.
Okay, no
Yeah.
aggravating
Yeah,
factors,
sound
relieving factors. Okay. Now you have written left-sided and right-sided. Agreed. Now,
sir.
is there any condition where we can have
sound.
nasal obstruction?
Sorry, sir.
Is there any condition where there is unilateral nasal obstruction that would turn bilateral? Initially unilateral nasal obstruction, then later on turn.
Androcrinal polyp.
Okay.
And
What else? So what should be the answer? The nose to nasal pharynx
would produce
can cause
unilateral.
bilateral nasal after being unilateral.
Okay.
Okay, this is the idea.
Okay.
Okay. Right. Please carry on.
He also had associated loss of smell for the past 2 years, which was insidious in onset. Initially had a decreased smell perception for around 6 months, which has progressed to a complete loss of smell thereafter, and there is no aggravating or relieving factors.
What is complete loss of smell known as?
Anosmia, sir.
How will you confirm that? Whether he had complete loss of smell or not?
Smell test.
That is your clinical examination.
Yes.
Patient exaggerate the symptoms. What else will you ask him? If the patient has anosmia, there is a common accompaniment. What is it? It need not be there in all cases, but still.
Decreased appetite.
It is not appetite, something else. Loss of smell will be associated with loss of
weight loss.
Loss of
what goes together? Smell and
taste sensation.
That's it. Loss of smell is associated with loss of taste. Okay. What is the most common cause of anosmia?
Allergic rhinitis.
Allergic rhinitis causes more of hyposmia, not anosmia. So I'm asking you, what is the most common cause of anosmia?
Any anatomical abnormalities that blocks the air from coming in contact with the olfactory mucosa.
That is not an answer. What is the most common cause of anosmia? I asked you what is the most common cause. Common. What? You have the answer in that. Most common cause of anosmia is viral. Common cold is the most common cause. Influenza. Okay.
Okay, sir.
Viral.
Okay, sir.
Of any viral disease which has caused anosmia?
It's a COVID-19.
That's it. When 2 years back, you had anosmia. In most of the cases of COVID-19, there was associated what?
Anosmia.
Associated what? Associated with? Anosmia was associated with?
Parosmia later on.
There was a loss of taste as well. Majority of the patients who had anosmia, there was loss of. That's why I asked you the question. Okay.
Okay, sir.
Right. Okay.
Okay.
Continue.
Sir, video stuck.
Slide
okay.
stuck.
He also had mass per left nostril for the past 1.5 years, which was noticed by the patient at the nasal vestibule on self-examination mirror. It was gradually increasing in size, not related to treatment, which included nasal sprays from multiple centers. He had associated nasal discharge intermittently from both nostrils, mucopurulent, non-foul smelling, and not blood-stained.
Okay. Why foul smelling? What is the importance of foul smelling discharge?
The foul smelling discharge could be any infective pathology, like as in case of sinusitis.
What sinusitis causes really foul smelling discharge? What type of
bacterial sinusitis?
Can you be more specific? Any localized sinusitis? Any disease? Localized disease?
Nasal tuberculosis.
No. I'm asking about localized sinusitis. Is there any localized maxillary sinusitis that causes really foul smelling nasal discharge? What about dental origin sinusitis? Dental
Yes,
odogen
sir,
sinus.
foul. It is associated with foul smelling.
So it causes foul smelling discharge. Okay, dendrogenic sinusitis.
Okay, sir.
Agreed, all chronic rhinosinusitis can cause foul smelling discharge, but specific, right?
Okay, sir.
Right.
May I change, sir?
Yeah.
So this was the mass per left. This was his mass per left nostril.
So for the 2 years he
also-
had 2 years he had nasal symptoms, and after 6 months he had mask coming out of the nose. Is it?
Yes, sir. After 6 months only, he noticed the mass coming out. Left
Maybe it was
nostril.
there earlier. We don't know. Okay, agree.
Yes. He also had a single episode of nasal bleeding from the left nostril 6 months back, which was spontaneous in onset, had few drops of blood, and it subsided on its own. There was a swelling on the left side. He also developed a swelling on the left side of the forehead for 3 months. The swelling initially developed the swelling of the left upper eyelid 3 months back, which progressed to the root of nose and then to the forehead over the eyebrows.
Bloodstained nasal discharge. Jude, please.
Bleeding
MRO.
and bleed or blood tinged.
ഓട്ടോ റൈനോ നിങ്ങളെ പോയി നിങ്ങൾക്ക് നിങ്ങളുടെ കയ്യിലല്ല
Sorry, sir.
തന്മയ്
Hello.
Hello, sir.
Yeah.
Continue.
Sir, sorry, sir. I couldn't hear I couldn't hear the question.
Yeah. You told a single episode of bleeding from left nostril,
Yes, sir.
and it is a frank bleed or a blood mixed discharge.
No, sir. He had a frank bleeding. Only a few drops of blood.
So it was bloodstained discharge, is it?
Sorry, discharge. He used to have nasal discharge, which was not bloodstained, but he had a single episode of bleeding from the.
Okay, it is not bloodstained discharge, it was bleeding from the nose.
Yes, sir, bleeding. It was an episode of bleeding.
What are the common conditions that can cause bloodstained discharge from unit at one nose?
Foreign body nostrils.
Foreign body, definitely. Then
And the vascular lesions like hemangioma or rhinosporidium.
okay, rhinosporidium can cause. Then
Infections like sinusitis.
yeah, that's the most common cause. Sinusitis, infection by sinusitis, that's the most common cause. And in specifically in sinusitis, which
Hello,
type
sir.
of sinusitis can causes bloodstained discharge from one nose?
Hello, sir.
Which type of sinusitis specifically causes bloodstained discharge from one nose? Unilateral bloodstained discharge. Which type of sinusitis?
Sir, I think there is some connection issue.
I'm not audible?
Sir, you are not audible. You are audible at present.
Okay. So bloodstained discharge from one nose. You can hear me?
Yes, sir, I can hear you.
You told sinusitis is a common cause. Which type of sinusitis causes bloodstained discharge from one nose? Which type of sinusitis specifically?
Bacterial sinusitis. Sir.
What is the best method to answer that? Which type causes unilateral sinusitis? Unilateral sinusitis, which subdivision of sinusitis causes unilateral disease?
Fungal sinusitis.
That's it. Fungal sinusitis, especially mycetoma or even AFRS, causes bloodstained discharge. Okay.
Okay, sir. Okay. He also developed a swelling on the left side of the forehead for the past 3 months, which initially developed a swelling of the left upper eyelid 3 months back, which progressed to the root of nose and then to the forehead over the eyebrows. So this was the swelling. He had associated headache on bilateral frontal region for the past 3 months, intermittent dull aching pain, which relieves with medication. There was no aggravating factors, no associated nausea, vomiting, photophobia or phonophobia. There was no diurnal variation in headache.
Why you ask for diurnal variation in headache?
Sir, there are there are certain types of headache which is associated with diurnal
1
variation.
second.
In case of frontal, in case of frontal sinusitis, which is also called Opie's headache, which is more common in during morning hours.
Anjana, one point. See, these are all what UGs learn. Okay.
Sir.
Now we should understand that isolated frontal sinusitis is extremely rare.
Yes.
And early morning headaches, office headaches, all these are just PG teaching. Let's come to PT level and tell me what type of headache is more common in the morning. Okay, forget about it.
Yes.
You now have a lesion inside the nose. It is already evident. You told there is a mass coming out of the nose.
Okay.
It is almost 1.5 years mass coming out of the nose, and after that it produces swelling on the forehead.
Okay, sir.
And the patient has headache. Now tell me, what can be the causes of headache in this patient?
Either it can be periosteal.
മറ്റ് ഞാൻ വേറെ ഒരു ഇതില് ടാബിലോട്ട് കയറി അതിൽ വോയിസ് കേൾക്കുന്നില്ല, അതുകൊണ്ട് ഞാൻ വേറെ ഒരു ഇൻസ്ട്രുമെന്റിലോട്ടാണ് കയറിയത്, ഫോണിലോട്ട്. അതൊന്ന് കോവാസ്റ്റ് ആക്കി തരുമോ? വീഡിയോ കാണാൻ പറ്റും.
You got my question?
Yes, sir. I got it.
So what can be the cause of headache? Considering you have a disease symptoms, there was a mass coming out of the nose. Now there is a swelling. Okay. What all can be? What are the different causes of headaches in this patient?
Either it could be due to the periosteal reaction which occurs secondary to the inflammation, or it can be due to the mass obstructing the frontal sinus.
One thing is sinusitis. Agree. Is there any other cause?
Yes,
causes? Any cause? Anything else?
If the mass is if the mass is producing a if it is invading into the nerves of the area, it could produce a.
Okay, it can produce neuralgic headaches. Agree.
Neuralgic
Which nerve?
headache.
Which nerve? Can invade the infraorbital nerve, it can invade other branches, orbital, I mean, ophthalmic branches, it can invade. So, the neuralgic headaches too is possibly. Then number 3, sinusitis can cause headaches. Neuralgias can be due to involvement of nerves. What else? What are other reasons for headaches in this patient? That is how we come at a diagnosis.
Answer. I need that. It is eroding the bone, and if it is invading into the anterior cranial fossa, and if it produces a dural irritation.
Very good. Good. Yeah, before that, eroding the bone. So, what do you call that? Eroding the bone means skull base.
Yes, sir.
Agreed. Skull base erosion is a third cause of
sir.
headache. Fourth, you already told if it is going intracranially, dural irritation. It is pain sensitive. It can cause headaches. Okay, so meningitis or dural irritation. And finally, intracranial lesions. If it causes headaches. Now, mind you, your intracranial space occupying lesion that causes increased intracranial tension actually produces early morning headaches. That is why you asked the question earlier.
Okay,
Get
sir.
the point. That is why you asked the question earlier. Early morning.
Okay, sir.
Okay.
So, compression of the orbit also can cause localized headache.
That's it.
Okay, sir.
Increased intraorbital tension can cause headaches as well.
Okay, sir.
Why do we discuss like this? This is because we need to come at a diagnosis from history and then go on to the physical exam.
Okay, sir.
You get the
Okay,
point?
sir. Okay.
That is why you classify all these things. Right.
There was no history of postnasal dripping, no history of ear pain, ear discharge, tinnitus, hard of hearing, or vertigo. There was no history of sore throat, dysphagia, or odynophagia. No history of fever, diplopia, blurring of vision, watering of eyes, or change in behavior. There
You,
was no history.
You specifically asked for diplopia? Sure.
Yes.
Because so much of compression of the orbit, there should be some sort of display blockade. That's why I asked you. You're sure?
Yes, sir. He didn't have diplopia, sir.
Okay, fine.
There was no history of loss of weight or loss of appetite. There was no history of
No,
bone
it's
bath.
no, it's still dip bath. Okay.
Okay. So can I move on, sir?
Yeah. Past history.
Past history. He had a history of nasal surgery 2 times in the past for nasal mass. First surgery done 20 years back and second surgery done 16 years back. No non-comorbidities.
That is incomplete. That history is incomplete. Extremely important. Why? Because you have a disease. You think this is a straightforward easy case, it can be easily managed, or you think this is a complicated case? I'm just
No,
asking you, Anjan.
It's a complicated case.
That means that there is a history of 2 previous surgeries. That means that you should have taken a better history of the previous surgeries, isn't it? So how will you ask the history there?
What was the complaint for which he had consulted?
That's it. Then
What was the duration of the complaints for which?
agreed. You should ask history about. You should ask about the history of the disease. More importantly, what about the surgery involved? How will you ask history of surgery? You should know whether it's a major surgery or minor surgery. How long the surgery was involved? Whether it was done under G or local.
Okay, sir.
Right? What about the post-operative management? Was it in an ICU? How long he was in the hospital? What was the post-operative follow-up? Don't you think all this has to be asked?
Yes, sir.
Especially in a case like this?
Yes, sir. Yes.
That's it. So you cannot just finish off by saying there were 2 surgeries. You should go into the efficacy surgeries. Okay. And in which surgery was done? You are written there. See, you're not written there.
And regarding this,
Whether it was done on the right.
and regarding this surgeries, it has been done 20 years back, and within a gap of 4 years, he has again gone for a second surgery. You don't know whether it is a revision for the same complaint or whether he has developed any complications related to that. We don't know.
That's it.
Oh,
And whether it is endoscopic surgery or open, that also plays a vital role.
okay. Surgery was endoscopic, sir.
How long? What was the duration?
Specifically, these complaints resolve after the surgery and did it recur, or was it persistent in spite of the surgery?
After the first surgery, he was asymptomatic for 2 years, and then he had the same complaint thereafter. And after the second surgery, he was 2 years he again started developing the same complaints.
You have written no non-comorbidities. What comorbidity
Yes.
are you going to ask? This page.
There was no history of hypertension, dyslipidemia, diabetes mellitus, no history of bronchial asthma.
Why is it important in this case?
Because the patient had presented with a complaint of nasal mass. So bronchial asthma history would be important. Sir.
So you're thinking about it. Before that, you started with hypertension. What is that? Diabetes mellitus, dyslipidemia. Is it important? This patient? You need not be biased. You need not be biased on seeing the mass there. Okay, you are just presenting a case. You are presenting a nasal case where the patient's complaint is bilateral nasal obstruction.
Okay.
And now I am asking you, is history of hypertension, diabetes mellitus, dyslipidemia important? That's all.
Sir, certain antihypertensive drugs are associated with complaints of nasal.
Okay. What can bilateral nasal obstruction produce? Already you told the patient has that. You told the patient has mouth breathing and snoring, isn't it?
Yes, sir. Yes.
So how is it related to hypertension, cardiovascular disease? How is it related to diabetes mellitus?
The patient can have obstructive sleep apnea and metabolic syndrome, which can produce hypertension, dyslipidemia, and diabetes.
That's it. That's the answer.
Okay, sir.
OSA. Sequelae of OSA is important.
Okay. Yes.
Okay. What about asthma? You talk something about asthma. What is it?
There is something like something called Samter's triad, which is associated with nasal polyposis, aspirin hypersensitivity, and bronchial asthma. So that has to be ruled out.
Anything else? Since you brought up the topic, I was not planning to ask this, but since you brought up the topic, you are talking about asthma, wheeze, or any lower respiratory involvement. What are the other conditions where you can have lower respiratory involvement in a nasal disease?
Granulomatous, granulomatous conditions of the nose are associated with upper and lower respiratory tract involvement.
Very good, very good. Which all granulomatous conditions?
Cyanosis, eosinophilic granulomatosis meningitis.
Eosinophilic granulomatosis polyangiitis, also known as Church-Strauss syndrome. Very good.
Church-Strauss syndrome.
Then
vaginous granulomatosis.
Vaginous granulomatosis.
Tuberculosis.
Tuberculosis. Then what about rhinoscleroma?
Yes, rhinoscleroma.
So all these granulomatous diseases may be associated with lower respiratory involvement. So that is significantly important, isn't it?
Okay, sir.
I think you should specifically mention there is no history of hypertension, diabetes mellitus, dyslipidemia. You should say there is no lower respiratory symptoms, or you should say there is no history of asthma. At least say no history of asthma. Okay.
Okay, sir.
If you just think about a lot of conditions, rhinologic condition, there can be lower respiratory involvement. Again, you have your cystic fibrosis, you have cartilaginous syndrome, you have young syndrome.
Yes.
All these there are lower respiratory involvement. Okay.
Okay,
So
sir.
that is the significance of thinking about the lower respiratory tract in nasal cases. There is already a terminology. What is the terminology known as? One of your chapters in your textbook is known as what? That is known as unified airway. Okay, what is unified airway?
Lower respiratory tract and upper respiratory tract.
You have the same epithelium and same disease predilection, both airways. Agreed?
Yes, sir.
Okay, fine.
Personal history, mixed diet, sleep was disturbed, appetite normal, bowel and bladder habits normal, no history of allergic rhinitis, no non-drug allergy. He was an ex-smoker, stopped 3 months back, Pacquiao was 10, and he was an ex-alcoholic also.
See, actually, history of nasal allergy you should have brought up along with past history, not here. Okay. That's not a personal, that's past history. Okay, even your drug history is past history of illness, not here. Okay.
Okay, sir. Okay.
Why drug history is important?
So aspirin sensitivity.
Other than aspirin, anything else? Any other drugs? Nasal lesions, nasal symptoms? Any other drug?
Rhinitis, intranasal steroids, decongestants.
Okay. Rhinitis medicament. Anything
Rhinitis
else?
medicament.
Any other drug?
Then certain drugs are associated with
nasal congestion.
Congestion.
Which all drugs?
Sir, alpha methyl dopa.
Okay, very good. Antihypertensives, antiparkinsons, antipsychotics. Lot of drugs. Okay, your drugs for benign prostatic hypertrophy, alpha blockers. Lot of drugs are associated with nasal symptoms. So drug history is important.
Okay.
Okay. Yeah.
Oh. Family history. He was from a lower middle class family, married and has a son, and there was no history of similar illness in the family.
In this case, where the patient has a swelling in the forehead,
sir,
what will you? Why is family history important? The patient has a swelling in the forehead. There is swelling in the forehead, and then think about the nasal mass. Some nasal symptoms.
Pots, puffy tumor.
Pots, puffy tumor, right there. But that's not important in families. Family history, what should you ask for? You ask for family history of colonic polyposis with a forehead swelling?
Yes, sir.
Why?
Sir, Gardner syndrome.
That's it.
Yes.
Since it's a forehead swelling, the most common site of the most common benign tumor of Parnassus and osteoma, most common site is forehead bone.
Okay. Sir.
And osteoma may be familial when that is not Gardner syndrome, where there is associated polyps of the colon, which is 50% transmitted in the families. 50%, autosomal dominant. Okay.
Okay. Sir. Okay, sir.
What are the other rhinological lesions running in family? Just since you brought up the topic. We do not waste time. Nasal allergy, 30% family. Okay.
Okay, sir. Okay.
You agree with me?
Sorry, sir.
You agree with me? Nasal allergy.
Yes, sir. Yes.
What about Osler's disease?
Yes, sir. Osler-Weber endodysis.
Yeah, one of the diagnostic criteria itself is positive family history. Okay.
Okay, sir.
Right.
Justified. General examination. A patient was
Why
conscious.
smoking is important? Why smoking is important?
Sir, smoking. The smoking can predispose a patient to allergy and also to carcinomatous conditions.
Okay.
Okay.
Now, what do you forget about it? We'll talk about it. Now, since you have finished off history, can you just summarize your history?
Yes, sir. So, a 48-year-old gentleman was hailing from Karakulam and he was a carpenter, presented with complaints of bilateral nasal obstruction more towards the left side for the past 2 years, loss of smell perception for the past 2 years, a mass per left nostril for past 1.5 years, and a mass in the forehead for past 3 months. And
isn't it better to put it as long-standing nasal symptoms and mass in the nose, presenting with a short history of a swelling in the forehead, isn't it?
Yes, sir.
3 months.
Yes.
And with no other positive history, isn't it? With a history of let's say nasal
Single episode of nasal bleeding and associated headache.
Associated headache.
Yes.
No other positive history with history of 2 repeated surgeries in the past.
Yes, sir. And he was a smoker and alcoholic also.
Jude, anything else?
With this aspect, what do you think it could be? Some any possible diagnosis in your mind?
So, because he was operated twice, it could be any recurrent nasal lesion, like it can be any polyps or a benign tumor.
So, in a repeated surgeries for 2 times, 20 years back and 16 years back, the patient was symptom-free for the past 14 years, right?
Yes.
So after the second surgery.
Yes, sir. The patient was asymptomatic for the past 14 years.
Yeah. Do you think the same lesion could be the reason for this time also?
No, sir. Probably no, sir.
So any conditions of nose, it's more significant in revision surgeries or revision.
Inverted papilloma.
So that malignant transformation is more common in a repeated case, right?
Yes, sir.
Okay.
I don't know why you are fixed on benign lesions. Why you are fixed on benign lesions?
It can be malignant lesions also, sir.
Your first diagnosis is benign, isn't it? You told
Yes, sir.
like a polyp.
Yes, sir.
So you mean to say that benign lesions present like this?
No, it can also be a malignant lesion, sir.
It comes outside on the forehead.
No, it is very rare presentation. It can be a malignant lesion also.
Should be a malignant lesion, most probably.
Okay.
Jude, we have finished history.
Yes, sir.
Can we get the other examiners, other faculty, examiners in the audience to ask questions on history and then go on to the examination?
Yes, sir. Sure.
Yes, sir. Others?
other faculty in the audience, please can ask questions. Please ask questions on history so that we don't miss anything.
You can elaborate more on the effect of smoking and alcohol with relation to sinonasal benign lesions or malignant lesions. So since you have touched up the inverted papilloma, do you have any connections between smoking and alcohol with the inverted papilloma?
Yes, sir. Smokers are more prone for inverted papilloma. They have got a high risk of inverted papilloma and other allergic conditions also.
No, it is not like that.
So as such, smoking and alcohol doesn't have a direct etiology over inverted papilloma. So only the malignant transformation is more common in smokers.
Okay.
In smokers, the malignant transformation is more in inverted papilloma. It is not that inverted papilloma smoking predisposes.
Okay, sir.
So any other conditions having direct relation with smoking and alcohol?
Nasopharyngeal carcinoma, sir. Squamous cell carcinoma of nasal cavity.
Okay.
Squamous cell carcinoma of the sinonasal tract, smoking, great.
Okay.
What does smoking do? What is the problem with smoking?
The smoking impairs the mucociliary clearance of the mucosa. It impairs the ciliary motion, and so the protective mechanism of the nasal mucosa is lost, which predisposes the mucosa to inflammation and secondary infection.
Okay, good. It makes the mucus more thick and viscid.
Yes, sir.
Any other questions?
Any other question from any other examiner in the audience? Please.
No, sir, we can continue. No problem.
Okay. Okay. We continue with the examination.
Moving on to general examination. The patient was conscious and cooperative. He was oriented to time, place, and person. He was moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pitching pedal edema. He was afebrile. Pulse rate was 70 per minute. Regular rhythm, normal volume and character. Blood pressure was 110 by 70 millimeters of mercury in the right upper arm in sitting position. Respiratory rate was 16 per minute, abdominothoracic.
What all points should you have highlighted in this particular patient in general examination?
Sir, his higher mental
Why
functions
that
were
is
normal.
important?
Because this lesion there is a forehead lesion also, and
Okay, great. I understand your point. You
yes,
want to roll out an intracranial involvement. Great.
Intracranial involvement. So
Then what else? General examination. You have written no pallor. Is pallor important? Such cases.
yes, sir, if the patient
See, now the idea is the patient gives history of one episode of nasal bleeding. Okay.
yes, sir.
Nasal bleeding. We don't know how much of post-nasal bleeding was there. You have not history of malignant, have you?
No, sir.
That's it. So that is the importance of looking for pallor. Okay. Unseen blood loss. Is it important? It is important. Especially in such aggressive lesions, it is important. Okay. Already the patient says that his voice is different, isn't it?
Yes, sir.
So you should have made a note that this particular patient has what? Rhinolilia clausa. Have you written that?
No, sir.
No, you should write that. Okay. This patient has obvious Rhinolilia clausa. You write that. If it's a child, what else will you write? Child. Suppose it's a child. What else will you look for? Long-standing nasal obstruction.
Appearance of the child, appearance of face is also important.
Look for facial appearance, abnormal facies of child. Even this patient, you should always mention there is a facial asymmetry in the patient. Okay, in general examination. You can be specific later on, right?
Okay, sir. Okay.
Again, BP is important. Already we have mentioned that. Why blood pressure is important.
No, yes, sir. Yes, sir.
Okay.
Okay.
Carry
Moving on to systemic examination. Cardiovascular system, heart sounds were S1 and S2 were present and there was no murmurs.
Ideally,
Respiratory,
after general examination, you should go to the examination of nose and paralysis and then come to systemic examination. Okay.
okay, sir. Okay.
Agreed. No problem. You just continue here. Ideally, you should go to the examination of the specified system. I mean, where the examine the patient has a problem, and then go for systemic examination and then come back. Okay.
Okay, sir.
You can carry on now.
Okay. Respiratory system, normal vesicular breath sounds heard. Air entry was bilaterally equal. Gastrointestinal system, per abdomen soft, no organomegaly. Central nervous system, higher mental functions were normal. Cranial nerves, olfactory nerve, smell perception was absent via both nostrils. Optic nerve, visual acuity was normal.
How do you test for olfaction?
So smell test, sir.
How?
So the patient is asked to compress one nostril and a substance that coffee powder that is kept in a bottle is placed in front of the other nostril.
Why coffee powder? Why coffee powder?
So coffee powder or assafoetida, any substance which has got a strong sensation of.
Really? You will ask for a strong sensation, substance which has a strong sensation?
So familiar products.
That's it. Day-to-day orders. Okay. That is why you're using assafoetida or coffee powder. Day-to-day order. Patient may be doing that. So you told you will ask the patient to compress one nostril and then you will bring the coffee powder towards the nostril, is it?
Yes, sir.
Will you ask anything else? Will you do anything else, or will you make the patient do anything else?
Close the eyes.
That's it. The patient has to close the eye. Otherwise, patient can see the coffee powder and tell that this is coffee powder, isn't it?
Yes, sir. Yes.
And then what else will you instruct?
The smell is checked separately on both nostrils.
What else will you instruct? I am just going to the basics. Okay. Don't feel bad about it.
Yeah, okay.
What else will you instruct? You just keep it there and ask the patient.
Sorry, sir.
How do you appreciate smell? Anjana, how do you appreciate smell?
Sir, with
Will you ask the patient to sniff in actively?
yes, sir.
Why?
So that the smell comes in contact with the olfactory mucosa.
So tell me the physiological process involved there. Why should this be done? Why? What's the reason?
Because the olfactory mucosa is located on the roof of the nostril. So the airflow has to be present so that the patient is able to perceive the smell.
Your Scott Brown says only 10% of the inhaled air comes to the olfactory area in normal inspiration. That means that you have to specifically instruct the patient to inhale actively inhale. Okay.
Okay.
Otherwise, the patient will not be able to appreciate smell. Okay. The other precaution is not touch the nose. Don't touch the nose. Just to bring just below the nose. Never touch the nose as well. Okay.
Okay.
Right.
What about the other dose?
So both nostrils are tested separately. So
using the same substance.
A different substance.
Oh, you should use a different substance because the patient doesn't know. He'll tend to re-identify the substance which he knows.
Okay.
If one nose is functioning and he smells coffee, if you ask him with the other nose, he'll still say it is coffee.
Okay, sir.
So you should have two different substances.
Okay, sir.
Continue.
What should you not use in testing smell?
So irritants should not be used.
Why? Why uterine should not be used?
Sir, pungent smell sensation.
Pungent smell sensation?
What will it stimulate? What will it stimulate?
It would stimulate the trigeminal nerve.
That's it. It leads to trigeminal stimulation. You don't want trigeminal stimulation. That's the reason why you use
Okay.
non-dependent orders. Okay.
Okay. Okay.
Right.
Okay.
You know any other standard test to test for
Sir, upset the kit that is used to test smell.
what is subset?
University of Peninsula smell identification kit, sir.
Any quantification method is there apart from this?
Any objective test. Objective test. These are all subjective. Any objective test.
Sorry, sir. I don't know.
You same like this thing your evoked response, but it's used only for not used in clinically as a routine tool.
Okay.
We have a butanol alcohol test where you can quantify smell also. Especially important when the patient is having some high cost.
Okay.
What is APSIT actually? What's the full form?
It's a University of Peninsula smell identification kit.
University of
Peninsula smell identification kit, sir.
Place. Which is the place?
University of Pennsylvania smell identification.
You told something else earlier. Okay.
University
of Pennsylvania. Okay. What is it actually? What is it actually? Just curious.
Sir, it is actually, there are certain 41.
40. 40 what?
40 different smell kits.
And then what does the patient do?
There is the patient has to fill a questionnaire, sir. It is a questionnaire based.
It is a scratch and sniff. Okay. It's a questionnaire. Okay, scratch and sniff. With the pencil itself, you can scratch and then sniff and then answer the question. Almost
Okay, sir.
Right. Continue.
Trigeminal nerve sensation over the face. It was normal bilaterally. Corneal reflex present bilaterally on both eyes. Conjunctival reflex present on both eyes. Facial nerve, taste sensation was present on the anterior two-thirds of the tongue, able to frown and raise the eyebrows. Auditory nerve, hearing was normal. Glossopharyngeal nerve, gag reflex and palatal reflex present and was normal. Vagal nerve, swallowing and speech is normal. Spinal accessory is able to shrug the shoulders and neck movements normal. Hypoglossal nerve is also normal. The protrusion of tongue is present and is normal. No wasting or fasciculations or fibrillations.
Can you come to the previous slide? Now, you talked about cranial nerve examination. Okay, in this particular patient, which of the cranial nerve examination is important? Very important.
Sir, olfactory is important. Third, fourth, and sixth cranial nerves are important.
Okay.
And
anything else?
Sir, facial.
The facial.
9, 10, 11.
No. More important, there are other cranial nerves. Let me ask you, you already have a patient who has swelling on the forehead, something like a proptosis. Okay.
Optic, sir, optic.
Why didn't you talk about optic now?
Oh, optic, sir, optic.
Now, agreed. In optic now, you have written something there. What have you written there? Have you written anything there?
Visual acuity was normal.
You have just written visual acuity. Is there anything else is important there? It's optic now.
Color vision is important.
Anything else is very important in this case, for this particular case?
Field of vision.
Not field of vision, something else. You should have done a specific test in this particular case. Which is that test? Could you look for the pupil here?
Yes, sir.
Why?
Horner syndrome.
Not Horner syndrome, something else. What is RAPD?
RAPD, relative afferent pupillary defect, sir.
Why is it important here?
Compression of the optic nerve.
That's it. When there is a lesion which there is compressing the optic nerve, you have to look for RAPD. How do you look for RAPD? RAPD is relative afferent pupillary defect. How do you look for that? What's the name of the test? Okay, we not waste time. Name of the test is swinging flashlight test. Okay, you swing.
Okay, sir. Okay.
Light is swung on both eyes alternatively. Look for inconsistent pupillary reflex. Okay.
Okay,
There is
sir.
no big contraction there, constriction there.
Okay, sir.
Why 346 involvement cranial are important here?
Sir, if there is intracranial extension of the, if the lesion has got intracranial extension, this can produce pressure effects upon the nerves.
Where? It's not intracranial. Where? Exactly where?
Superior orbital fissure and then to the cavernous sinus.
It is intraorbital extension, superior orbital fissure, orbital apex, cavernous sinus involvement. That means that other cranial nerve important is fifth cranial nerve, trigeminal nerve. You can have trigeminal nerve aspect. So all this examination is extremely important in this particular case. Agree?
Okay. Okay, sir.
Right. Carry on.
Local examination. Examination of face. On inspection, the patient had facial asymmetry. There was a 7 into 5 centimeter single oval swelling on the left side of the forehead, extending up to the glabella and to the root of nose medially, to the level corresponding to lateral canthus laterally, inferiorly up to the level of medial canthus of the left eye, and superiorly 1.5 centimeter above the level of supraorbital ridge, and surface appeared smooth.
Okay. Ideally, you should come to this after your nasal examination. Okay. Continue.
Okay,
Continue.
there was no dilated veins or visible pulsations over the swelling. Skin over the swelling was normal. The swelling was seen pushing the left eyeball downwards and laterally. On palpation, there was no local rise in temperature. Tenderness was present. Things of inspection were confirmed. There was a immobile smooth swelling which was form and consistency. Margins regular and was felt on all sides. There was no fluctuation, no translucency, not reducible, not compressible, no pulsations felt. Skin over the swelling was pinchable. And on auscultation, there was no bruit or murmur.
Lot of gray areas there. Now, you mean to say that you have a firm swelling there, is it? So firm swelling means it is not a bony swelling, isn't it?
Yes, sir. No, sir, it was not a bony swelling. It was.
If it is not, tell me no, because I have not seen the case. I just seen the.
Yes. No, it was no, sir. It was
So
a
you
firm
mean to say
swelling. It
that
is
there
not a
is a
bony
lesion
swelling.
just beneath the skin, above the bone, is it? Okay. If it was a
Yes,
thinned
sir.
out bone, what else would I look for? What other examination would you look for? Thinned out bone. What do you call that? When you compress the bone, something happens. What is that known as?
Crackling.
Extra crackling. Should I look for extra crackling?
Actual
Okay.
crackling. Yes, sir.
Right. And then what is your return? Just show me the next slide. You have written no translucency, no fixity, not reducible, not compressible, no pulsations felt. Why? Why you have asked for this?
There was no fluctuation because in order to rule out mucosal or similar lesions.
Mucosal is not fluctuation. Mucosal is axial crackling.
Okay, sir.
Aphasia is actually an abscess or something. Okay.
Okay.
Then what else?
Translucency. So the swelling would not be translucent if it is a mass lesion. If it is a cystic lesion or mucosal-like lesion, it would be translucent.
Then
it is not reducible. Reducible and compressible. It is for similar lesions. Like the hemangioma, it would be compressible.
Which other lesion there is more important if it is reducible?
Meningocele.
That's it. Meningocele. So
Okay.
what other tests would you do to know whether it is a meningocele or not?
Transillumination test.
Transillumination, no. Anything else? Would you look for an impulse on coughing?
Yes, sir. Yes.
Look for impulse on coughing, or what is it known as? Suppose you are compressing the jugular vein. Suppose you are compressing the jugular vein, there is an increase in size of the swelling. What is that known as? And this is seen in meningocele and encephalocele. That is known as. This is known as Furstenberg sign. Okay, Furstenberg sign.
Okay, sir. Okay.
When there is an increase in intracranial tension, it bulges out. So that means that there is a swelling which is communicating with the intracranial cavity. Agreed.
Okay, sir.
Okay, fine. Continue.
Okay. ENT examination. Nose. There was a fullness present in the region between left medial canthus and dorsum of nose. There was increased intercanthal distance. Skin over the nose was normal. Columella was normal. External nares normal. Nothing
else? Just show me the photograph. Nothing. This particular photograph. You're looking at the photograph. Anything else? You have just written what? Fullness between the medial canthus and dorsum of nose. More importantly, I think there is widening of the nasal dorsum, widening of the nasal bridge. There is flattening of the nasal dorsum. There is widening of intercanthal distance. All these are suggestive of what? He almost looks like what? What deformity? Almost looks like a frog face deformity.
Yes.
Okay, almost. Okay. Now tell me, what conditions will there be a widening of intercanthal distance and flattening of nasal dorsum? What are the conditions?
Any lesions with a breach in the lamina papracia? That is if there is a ethmoidal polyps are able to produce.
There is no need for a breach in the lamina papracia. Anything which causes expansion of the ethmoids. So it can be seen in extensive ethmoidal polyps. Anything else?
Fibrous dysplasia.
Agreed. Fibrous dysplasia. Anything else?
A mucosal that involves the ethmoids.
Mucosal with ethmoids. Anything else?
Dermoids.
What are the lesions of the ethmoid? Malignancy of the ethmoids? Why not?
Yes, sir. A malignancy of the ethmoid.
What about a lesion which arises directly from the ethmoid? I mean, in the ethmoidal area, I mean, high up in the nose. It can involve the ethmoids. What about olfactory neuroblastoma?
Yes, sir. Olfactory neuroblastoma.
All these lesions, intranasal meningocele, all these lesions actually can produce widening of the intercanthal distance and flattening of the nasal dorsum. Okay.
Okay, sir. Okay.
Continue.
So functional test. Cold spatula test, there was absent fogging on the left side and minimal fogging on the right side. Potter's test was negative.
Since this is a teaching program,
sir,
just tell me what are the pitfalls? How do you do a cold spatula test?
A cool tongue spatula is brought in front of the nose and patient is asked to breathe out normally. And
you will ask the patient. You will ask the patient to breathe out normally.
No, sir. We place a cold spatula just in front of the nose.
Okay, and then you are looking for condensation. You are looking for condensation. Okay. Yes. What are the pitfalls of a cold spatula test? What are the pitfalls of a cold spatula test? You need to say that what we describe is when there is less of fogging or condensation on one side, you say that nose is partially obstructed, isn't it?
Yes, sir.
What are the pitfalls of a cold spatula test?
There is no standard assessment of fogging for that's amount
not
of
a
obstruction. There is
that is not a pitfall. Anything else? Pitfall, there should be no nasal pathology, but still one knows condensation is less as compared to other.
yes,
Which
because of
condition?
the nasal cycle, normal nasal
That's
cycle which occurs.
That's it. That's the first thing. You should always account for the nasal cycle, number one.
Yes.
Anything else? Any other pitfall? You are checking this during quiet respiration. Any other pitfall? Full standard test.
If the patient forceful expiration would produce erroneous result.
You're checking for during quiet respiration. Is there any condition where there is nasal obstruction during forceful respiration?
If anthropoidal polyp would produce.
It is not an anthropoidal polyp. Suppose a patient has a collapsing ala.
Okay.
You will always miss that. Okay. Those lesions is on a cold spot. The patient may have nasal obstruction. You look cold spot just you see, you feel that there is no nasal obstruction. Actually, he has a dynamic obstruction here. Okay.
Okay, sir.
Right.
Cordel's test was negative and smell test was absent. He was not able to perceive smell bilaterally.
Why did you do a Cordel's test here?
Sir, in order to assess the area of internal nasal valve.
Why? Already you have a huge lesion which is coming out. What is the point of doing a Cordel's test? I think it is not needed here.
Okay.
How will you do a Cordel's test?
So pull the cheek laterally and ask the patient whether the obstruction is relieved or not. If the obstruction is relieved, means Cordel's test is positive.
What is the pitfall of a Cordel's test?
Sir, if lower lateral cartilage,
Upper lateral cartilage.
Upper lateral cartilage, sir. If there is a prolapse of the upper lateral cartilage, then the Cordel's test would be negative.
Dynamic obstructions will be negative. Yes. Okay.
Yes.
More importantly, understand any patient, any person, you pull the cheek outside, there will be opening up of the nasal valve. You'll say it is better.
Yes.
So it doesn't have any diagnostic reliability. That's a problem. Okay. What's better method of doing Cordel's test rather than to describe?
A modified Cordel's test is available, sir.
What is that?
Here we use an instrument in order to lateralize the lower border of the upper lateral cartilage.
A rigid instrument is used.
Yes.
Okay.
Anterior rhinoscopy, vestibule, left side, left vestibule, there was a pinkish lobulated mass and mucopurulent discharge was present. Right vestibule was normal. Septum, mild dilated nasal septum, mild DNS to right. Left
just a moment. How do you do a anterior rhinoscopy? How will you proceed with the examination of it? Again, teaching program, I am going to the basics. Okay,
sir. Okay.
How will you proceed with the examination of nose here? After external appearance, how will you proceed? What is the next thing to do? You have already told about cold spandard test. Okay. You have already told about cold spandard test. Then what?
Columella, vestibule.
How will you examine that?
On raising the tip of the nose.
You examine that raising the tip of the nose. Why?
For visualization.
You have written anterior rhinoscopy already, and then you told columella and vestibule.
Okay, sir. Okay.
And it's done using a Tudicum speculum.
Okay.
Here, you lift up the tip of the nose and visualize the nasal cavity, so that you don't need what lesions like
lesions in the pharyngeal and
more importantly, caudal dislocation of septum. Again, in children, it is always better to lift up the tip of the nose and see. Okay.
Okay, sir.
Right. How do you use the Puticum speculum? Basic question.
The index finger is placed inside.
Okay, I know how you hold that. What are the precautions you should take when you're using Puticum speculum?
It should be held on the left hand and should not press against the septum.
Is it should not press against the test or something else? Open it up. How do you introduce the Puticum speculum?
You have to introduce it closed and then open.
Open it. Open it. Open it to the vestibule. Okay. Open it laterally onto the skin, not medially on the septum. And how do you remove that? How do you remove that?
Sorry, sir.
How do you remove the speculum?
Sir, we have to.
You told you will introduce the speculum fully closed.
Yes, sir.
How do you remove the speculum?
So we have to remove it like that. So we should not close the speculum while removing.
That's it. While removing, it should be partially open. Otherwise, you will pinch on the vibrissae. Okay.
Okay, sir.
Right. Continue.
Left nasal cavity. There was a pinkish lobulated mass filling the left nostril, reaching to a level just behind the external nares. On probing, the swelling was soft, insensitive to touch, bleeds on touch, and probe cannot be passed superiorly and medially. Floor, lateral wall, and roof was not visible.
So you mean to say, from where does the mass arise?
Immediately, the mass was seen extending through a dehiscence on the septum to the opposite side, sir, and superiorly also we couldn't pass the probe, so probably it was arising from the roof of the sinus.
It is arising the roof of the nose, nasal wall, is it?
Yes, roof of the nasal wall. Sir.
Okay. It is sensitive to touch or insensitive?
It was insensitive, sir. Insensitive to touch.
Okay. That is highly unlikely.
So both the roof and medial wall you are not able to probe, right?
Yes, sir. Medially, the swelling was found extending to the other side also. So a right nasal cavity, there was again a pinkish lobulated mass seen medial to the right middle turbinate, reaching up to the anterior end of the right middle turbinate. And on probing, it was a soft mass, insensitive to touch and bleeds on touch. A probe could not be passed superiorly and medially, and visualized part of the floor and lateral wall was normal.
How do you visualize the floor and how will you look for the floor and roof of the nasal cavity? In annual rhinoscopy, how are you visualizing? How do you visualize the roof and floor of the nasal cavity?
Sir, a roof, floor can be visualized.
How? To visualize the roof and visualize the floor of the nasal cavity makes two extremes. How do you do that? This is done by tilting the head of the patient, isn't it?
Okay, sir.
All these are basic questions. Okay.
Okay.
Right.
Okay. So posterior rhinoscopy, there was an irregular pinkish lobulated mass filling the left choanae and partially obstructing the right choanae. Posterior end of the septum was not seen. Left eustachian tube orifice was not seen. Right eustachian tube orifice was normal. Roof was not seen. Soft palate was normal.
How do you do a posterior rhinoscopic examination?
Initially, ask the patient to open the mouth and use a tongue depressor to lower the tongue. Warm the mirror and introduce the mirror along the lateral aspect of the nose, lateral aspect of the mouth. That's the angle of mouth, and pass it behind the soft palate.
What is the practical difficulty in visualizing the nasopharynx in posterior rhinoscopy?
Sir, a soft palate would be obstructing the view of the nasopharynx.
Contraction of the soft palate is a practical difficulty. So how do you avoid contraction of soft palate during posterior rhinoscopy?
Ask the patient to breathe through the nose.
That's it. Very good. Ask the patient to breathe through the nose.
Okay.
Okay.
Now examination of paranasal sinuses. Right frontal sinus tenderness was present. There was a tender mass over the region of left frontal sinus. And right ethmoidal sinus was non-tender. Left ethmoidal sinus tenderness could not be elicited due to overlying mass. Maxillary sinus, it was non-tender bilaterally.
Not very important.
Examination of orbit. The left eye was seen pushed
How will you look for
laterally with
proptosis?
mild proptosis. There was restriction. The proptosis, the examiner has to stand behind the patient, and the patient is asked to extend the neck, and the examiner has to stand behind and look at the level of supraorbital ridge or superior orbital margin. If the eye is seen protruding over the level of supraorbital ridge, means the patient has got proptosis.
What are the pitfalls? You're looking for proptosis. What are the you're standing behind the patient, you're peering down onto the chin of the patient from the forehead. This is the idea, isn't it?
Yes, sir.
And, you're looking for proptosis by looking from up. What are the pitfalls in evaluating proptosis?
Sir, if abnormalities in skull shape can.
Okay, what's skull shape? I don't know whether you meant that. If it is a shallow orbit, the eyeball may appear protruded out. Okay. Okay. Anything else? All these conditions are known as pseudoproptosis. So what are the conditions where are the situations where you can get pseudoproptosis? That's the question actually.
Okay, sir.
One is a shallow orbit, eyeball is protruding out. Then what else?
Sorry, sir.
Second one is high myopia. Patients having high myopia. Okay.
Okay, sir.
Third one is lid retraction. Suppose the lid is retracted, you will see clearer. You might think that the eyeball is protruding. Okay.
Okay.
And suppose there is a small eye on one side. It is not a proptosis on one side. Rather, the opposite eye is small. Ophthalmos on one side. You might actually think it is proptosis on the opposite side. Get the point?
Okay, sir. Okay.
All these are conditions causing pseudoproptosis.
Okay, sir.
What's the difference between proptosis and exophthalmos?
Sir, in exophthalmos, the proliferation of the retroorbital fat tissue.
Almost always this is used interchangeably. Is there any difference between the two?
No idea.
Okay, proptosis actually can occur in other organs as well. Okay. Exophthalmos specifically for the eye. This is the idea.
Okay, sir. Okay.
Right. And again in endocrinopathies, as you are told, retroorbital tissue, actually they specifically call that exophthalmos rather than proptosis.
Okay, sir.
Okay. What is the problem of patient having proptosis? What is the problem? Exophthalmos, what is the problem?
Exposure keratopathy.
Very good. That's the most important thing. Exposure keratopathy. Okay. Right.
So a left eye was being pushed infralaterally with mild proptosis. There was a restriction of movement superior. Corneal reflex was present and light reflex was present. Right eye was normal.
What is the implication here? The left eye is being pushed infralaterally, you have told. What does it mean?
The swelling which was arising from the nasal cavity is seen extending into the orbit, pushing the orbital contents.
Let me ask you, if it is from the nasal cavity, it should have pushed the orbit laterally. Here you have told the orbit is being pushed inferolaterally. What does it
Just
mean?
arising from the frontal sinus. Is
That's it. It should come from up. It should be from the frontal with some involvement of the ethmoids. That's why it is pushing inferolaterally. Examination of the orbit. Understanding the orbit, you should specifically report sensations around the orbit. Okay, sir. Okay. Infraorbital sensations.
Sensations were preserved.
Sensations
sensations were preserved.
Okay. Okay.
Oral cavity, angle of mouth was normal. Mouth opening was full. Lips, tongue, gum, gingival and gingival buccal. Anterior 2/3 of the tongue, floor of mouth, hard palate, soft palate, and retromolar trigon was normal. Anterior pillar, posterior pharyngeal wall was normal. Bilateral capsular hypertrophy was present. Indirect liposcopy was normal. So, ear examination, auditory region, pinna, post-auricular region, external auditory canal was normal. Tympanic membrane had a grade 1 retraction. Left side also, preauricular region, pinna, post-auricular region, and external auditory canal was normal. And tympanic membrane has grade 1 retraction. There was no tragal or mastoid tenderness. Tuning fork test was also normal, sir. Bilateral facial. No, sir. There is nothing possible.
Okay.
Vestibular test.
You can skip that.
Okay, sir.
Everything is normal, isn't it?
Yes, sir. Everything is normal. Neck, no visible swelling, structures, and no palpable neck veins.
You had written the provisional diagnosis. Before provisional diagnosis, why don't you sum up the case?
Okay, sir. So, just the examination findings or the total history, sir?
Sum up the case.
Okay.
Total.
Okay.
Total.
A 48-year-old male patient who presented with complaints of bilateral nasal obstruction for 2 years. Presented with all the nasal symptoms of nasal obstruction, loss of smell perception for 2 years, and a mass from the left nostril for 1.5 years, with the swelling on the forehead for 3 months. And he had associated mouth breathing and snoring also, and a single episode of bleeding associated 6 months before. He also had complaints of headache. On examination, a patient was found to have a asymmetrical face with a swelling on the forehead, which measures 7 into 5 centimeter, which was tender to touch, firm in consistency, and was immobile. Moving on to the examination of nose, there was a left nasal cavity showed a swelling, which was soft, insensitive to touch, which bleeds on touch.
Anjana, this is not summing up. Actually, you are just again telling me the findings. You sum up the case. Some of the case means it should be as short as possible. Get the point.
Okay, sir.
So, you ideally told you have a middle-aged man with history of 2 surgeries in the past who presented with a long-standing nasal symptoms and nasal mass with a short history of a mass on the forehead and history of bleeding from the single episode of bleeding from the nose. Examination has a mass in the nose with evidence of extension into the around the orbit and into the forehead. That's sufficient.
Okay.
This is how you summarize. When you summarize, don't tell, just again repeat the same case. So that actually will not aid in your diagnosis. You should always highlight those points which actually you want to highlight and go to your diagnosis, and you should suppress those you don't want in your diagnosis. This is the idea of summarizing the case. You should practice that beforehand when you present in the examination. It should be as short as possible, as crisp as possible. Get the idea?
Okay, sir. Okay.
Okay. So tell me, what is your diagnosis?
Sir, it could be a possible sinonasal neoplasm, most probably a benign because of the long-term history. can also be malignant because it has got a rapid progression.
Just show me your last slide. Next slide. Next slide. Yeah, you have already committed benign there. No, before that. I think you have already come with the mindset that it is benign. Okay. So tell me, what are your points in favor of benign?
Sir, the long-term history of the lesion. Because the patient...
All history is not long-term?
No, sir. The swelling over the forehead is only 3 months.
Yeah,
But
okay. And you were very specific that the forehead swelling is not bone. Forehead swelling is a lesion which has come out of bone, haven't you?
yes, sir. Yes.
So you have a lesion which has eroded the bone and come into the forehead. It has extended into the orbit as well. Evidence of extension to the orbit.
Yes, sir.
And how can you make a first diagnosis of benign lesion? And that's only 3 months duration.
Sir,
Agreed. All other symptoms are long-standing, but you have one symptom which is significantly important, which actually tells you that it has come outside.
yes.
How will you explain that?
It could be a malignant transformation of a benign swelling.
That's it. You should have told that.
Okay, sir. Okay.
That should have been a diagnosis. It can be a long-standing malignant, benign lesion, which might have turned malignant.
Okay, sir. Okay.
Just come to a differential diagnosis and discuss each one of them.
Sir, inverted
Just tell us what are the points in favor and what are the points against each one of these diagnoses. Okay.
Okay, sir.
You have written 4 differential diagnoses there, isn't it?
Yes, sir.
So tell the reasons in favor of the diagnosis and against the diagnosis.
Okay.
You can start with inverted papilloma.
So, inverted papilloma, because the patient has inverted papilloma is a tumor which has got a high rate of recurrence. This patient was operated 2 times in the past for same history. So it would, and again the lesion was in more on the left side, which has extended into the right side. So initially it developed as a unilateral lesion. So inverted papilloma is unilateral. And inverted papilloma is a benign tumor which has got a bone eroding property and intraorbital and intracranial extension also, especially when it involves the frontal and ethmoid sinuses. So in patient is a carpenter, and so inverted papilloma is more common among people who are working in wood industry. And it is a tumor which has got a propensity to turn into malignant tumor. 10% of the inverted
papilloma and wood dust is related, is it?
Yes, sir.
Okay, that is news for me. Anyway, okay. Then what is the reference?
Sir, Cummings, sir.
Okay,
fine.
Cummings. I will check that then.
Okay. And
what are the points?
Sorry, sir.
What are the points against?
Points against it. It was a bleeding it was a bleeding fibril or for soft and fibril lesion, and the attachment inverted papilloma is usually more common on the lateral wall of nose, but this tumor was found attached to the superior aspect.
Site of origin is not. Okay, right. Number 1. Number 2.
And the rapid progression of the lesion over the last 3 months.
Okay. Extension to the opposite side.
And extension to the opposite.
It is unilateral. Inverted papilloma is usually unilateral. If there are no harm, it should be unilateral, but it is not unilateral. No harm, it should not be unilateral, but here it is bilateral.
Yes, sir.
Or you told it is extended through a septal perforation on the opposite side. Is it?
Yes, sir. Yes.
Do you think the septal perforation was caused by inverted papilloma or something else?
Sir, it could be due to the pressure effect, which produces the bone erosion.
Anything else? Any other reason why it might have produced a septal perforation in the patient's history?
Previous surgery.
That's it. There are 2 surgeries previously. They are not. Okay.
Okay.
Then what about the second diagnosis?
So the points in favor of sinonasal malignancy is the rapid progression of.
Don't just say sinonasal malignancy. Be specific about the malignancy. Where malignancy, which sinonasal malignancy?
Squamous cell carcinoma.
Squamous cell carcinoma. I'm not talking the histological type. Malignancy where? Anatomical site of malignancy.
Okay. Frontal and frontoethmoidal complex.
Don't say frontoethmoidal complex. You want to say ethmoidal malignancy.
Okay, sir. Okay.
Right. Points in favor, points against.
The rapid progression of the lesion. Patient had an episode of bleeding, and the intraorbital and intracranial extension of the lesion, and the predisposing factors, that is woodworker. And
in fact, that should have been the first thing you should have told. Okay. In favor of malignancy is his occupation. In favor of malignancy.
Okay.
But 2 years of history, very unlikely to be ethmoidal malignancy. Why? Because ethmoidal malignancy rapidly would have gone into the orbit within no time.
Okay, sir.
So very unlikely to be an ethmoidal malignancy. And invariably it would have invaded the orbit. This is not invading the orbit like that. Because it is not invading even the muscles, it is not invading. So very unlikely.
Okay, sir.
Right. And then intracranial extension is also not proven from your examination. Intracranial extension. Okay.
Okay.
Then
olfactory neuroblastoma. The points in favor are patient had a history of loss of smell perception for the past 2 years, along with episode of nasal bleeding, and the mass was found vascular.
The point in favor of esthesioneuroblastoma is whatever symptoms are described in esthesioblastoma, neuroblastoma, it is there in the patient.
Yes.
Right from the beginning, the patient had a nasal obstruction. Patient had one episode of epistaxis. Very importantly, patient had loss of smell. It was loss of smell also. And then everything is there in favor. And against, again, what is the other point in favor of esthesioneuroblastoma?
The bimodal age distribution.
Anything else? What about the site of origin?
Arising from the roof of the nasal cavity.
You already told it arises in the roof of the nasal cavity.
Yes.
So site again in favor of olfactory neuroblastoma.
Okay.
Then what about the long duration? Is it possible?
Yes, sir.
Yes. Olfactory neuroblastoma, long duration is possible. It need not be rapidly progressing. Some cases it can exist for a long time before it produces symptoms.
Okay.
So everything there is favor of olfactory neuroblastoma. What is against?
When it becomes aggressive, it has got a rapid progression into the anterior cranial fossa producing symptoms.
Only point against it is not that very aggressive. That's all.
Sorry, sir.
Only point against is that it is not very aggressive. It's not very aggressive. Actually, you can have lesions which is not aggressive. Okay.
Okay.
I actually wonder why you didn't tell this as your first diagnosis. Olfactory neuroblastoma. I'm wondering.
Okay.
Maybe the point against is previous 2 surgeries earlier. Previous 2 surgeries earlier, and histopathology, he was never warned about that. Possibly it is not related. We don't know. Okay.
Okay, sir. Okay.
Is it a rhinospodium?
No, so the typical appearance of the lesion does not favor a rhinosporidium, and
it is never a rhinospodium. Why? One is your typical appearance. Anything else?
There was no predisposing factors.
Anything else?
It was a bilateral.
What is the most common presentation of rhinospodium?
Epistaxis.
That's it. Recurrent epistaxis. Here there is only one episode of self-limiting bleeding.
Okay.
Anything else, Jude?
Regarding inverted papilloma, that I'm not convinced about direct wood exposure is reason, because in literature mostly they used to say some solvents which they use in food industry may be the culprit.
Okay.
And the possibility of inverted papilloma going for a malignant change is common, especially around 5 to 15% of cases, especially recurrent cases, and that fits for the patient.
Okay, sir.
Olfactory neuroblastoma, as are told, the initial 2 surgeries may be for some other pathology, then there is a possibility.
Okay.
Shibu sir, about the olfactory neuroblastoma, if you have such a large olfactory neuroblastoma, it usually will have some amount of intracranial extension. It's very notorious for intracranial. I have not. That is my
Nishant,
understanding. So, what do you think?
We have not gone to the CT scan.
No. See, clinically.
Yeah. We are
Generally,
just talking about clinical. So
generally
clinically,
about
we have to tell this. After looking at the CT scan, maybe we'll go for something else. But what I'm telling is, clinically, you should always suspect olfactory neuroblastoma here. If the examination is right, what a lesion which is coming from the vault of the nose, which has extended to the opposite side, which has gone into the frontal sinus, which has gone, it is almost compressing the orbit, producing absolute anosmia and nasal obstruction, and not much of bleeding, but scattered bleeding. I think this is a strong possibility.
Okay.
I don't think rhinophobiosis can be a fit diagnosis here.
It should not be. It should never be told as a diagnosis.
Okay, sir. Okay.
Okay. How will you proceed with the case?
All the baseline investigations has to be done, including complete blood counts, renal function tests, blood glucose levels, etc. And biopsy, CT scan has to be done. A contrast enhanced CT has to be done of the nose and paranasal sinuses. A biopsy of the lesion.
Anjana, just give me some time. Okay.
Okay.
You are going to take a CT scan in this patient.
Yes.
You are the treating doctor. How are you going to write the order for CT scan? How will you write?
Contrast enhanced CT of the nose and paranasal, axial, coronal, and sagittal cuts.
Thickness?
0.6 mm, 0.675 mm.
0.6 mm. Why 0.6?
Okay. Normal CT is 1.2 mm. That's all.
1.2 mm. You doubled that, is it?
Yes.
Okay. Why do you want a contrast enhancement?
Because it is an unilateral nasal
This
mask.
particular case, 3 mm sections are sufficient. Okay, I'm just clarifying that. Okay, there is no need for high resolution cuts or anything here. Why? Because there is extension. Already you know about extension. Okay, suppose you are looking at thinking about very small spaces or very small defects, then agree. You should have thinner sections. Tears of rhinorrhea, example. Okay.
Okay, sir. Okay.
There's no need for such thin sections. But contrast enhancement, obviously. Why?
Because it initially presented as a unilateral nasal mask with intracranial intraorbital extension, the single episode of bleeding also. So
okay.
So what are the indications for MRI in the case of sinonasal pathology? In which conditions you will think of MRI?
Here the mass has got intraorbital extension and intracranial extensions. So we have to delineate the soft tissue involvement, and we have to distinguish the mass from secretion, mass from the mucus or collected secretions, and dural involvement has also to be differentiated with MRI.
That's it. Possibly more valuable would be an MRI. What are the advantages of taking an MRI here? Would it fit to the diagnosis?
Yes, sir.
How?
among the differential diagnosis, this inverted papilloma has got a typical appearance in MRI with a convoluted cerebriform pattern.
What is it? I don't know. What is convoluted cerebriform pattern? I don't understand. What is it?
Sir, sorry, sir.
You just mugged it up, is it?
What is the appearance?
Yes, sir.
What do you mean by
Mm.
convoluted cerebriform appearance? Okay, forget about it. Just alternate hypo and hyperintense lines. Just look at that. Just look at the M-node papilloma MRI when you see later on. Okay.
Okay,
Alternate
sir.
hypo and hyperintense lines, which is seen either on T1, which is enhanced, or T2 weighted images.
Okay.
It is almost like your cortical sulcus and gyrus in CT scan, I mean, of the brain, almost similar. That is why it is convoluted cerebriform pattern. Okay.
Okay, sir.
Now, convoluted cerebriform pattern may be absent in inverted papilloma. When
Malignant transformation.
in malignant transformation, it will be absent. Okay. So it is the same. In malignant transformation, your convoluted pattern will be
Okay.
absent. If it is asthetic neuroblastoma, how does it look like?
Sir, it has got post-contrast enhancement, soft tissue opacity with post-contrast enhancement and erosion into the intracranial, with intracranial extension also.
Is there any specific finding for olfactory neuroblastoma radiologically? No problem if you don't answer that. I don't think it. I think it's a difficult question, but still, you can see cyst around the lesion, especially in intracranial involvement. You can see peritumoral cyst.
Okay.
That is one method of differentiating that from other lesions. Okay, when there is extension,
Okay, sir.
peritumoral cysts are seen.
Okay, sir.
Then you told you will be you'll do all routine investigations. Then you told
Yes,
you will go for a CT scan or MRI.
Yes, sir.
Then what?
Biopsy of the lesion.
See, in an examination, you always go with the routine. When you go with the routine investigations, you should talk about other investigations and general investigations like your chest X and everything. Okay, all these are
Okay, sir.
important. We discuss that because here we are going with the preformed idea that it should be a tumor. Need not be a tumor. It can be anything else. That means that chest X-ray is extremely important. I am
Yes,
not
sir.
skipping some.
Yes, sir. Yes,
For
sir.
the want of time, we are going to the next thing. Okay.
Okay,
So,
sir.
what are you going to do next?
The patient, the treatment of choice has to be surgery.
Treatment of choice. You have done routine investigations. You have done CT scan. You have done MRI. You are going to do surgery.
Pre-op preparation.
Any other-
Biopsy of the lesion.
Then why didn't you tell that? You have
Yes,
to take a
sir.
biopsy.
Yes, sir.
So tell me, what are the precautions you do when you take a biopsy in this particular case? Possibly it's very important.
Okay, sir.
In the scenario, possibly the most important point towards your diagnosis is this. What precaution should you take?
Bleeding.
What bleeding? After all, there is only a single episode of bleeding.
Yes, sir.
You can control that. But biopsy is very important here. But when you do biopsy, you should take care to, you should remember to do dash. What? So the first diagnosis, we discussed about the diagnosis and then we came to a conclusion that this must be what? This can be what?
This can be a malignancy or a olfactory neuroblastoma or
What malignancy?
squamous cell carcinoma or
Before that, we were talking about a benign lesion like inverted papilloma, talking malignancy, isn't it?
yes, sir.
How does malignancy occur in inverted papilloma? Is it synchronous malignancy or is it metachronous malignancy?
Malignancy can coexist with the lesion or the
What is
lesion
more
can.
what is more common?
Coexisting malignancy.
That's it. Malignancy coexisting is more common. So what is the specific thing you should think about when you take a biopsy?
Biopsy has to be taken from multiple sites.
That's it. Exactly, that's it. You should take multiple biopsies. If you don't take multiple biopsies, you'll always mix a synchronous malignancy. Because malignancy can occur anywhere in the inverted papilloma. Even when the biopsy is negative, you have to think about a malignancy lurking somewhere. And post-operative, I mean, when you send for histopathology, you should be very clear with the pathologist that we suspect a malignant change in inverted papilloma. If at all it is inverted papilloma. Get the point?
Okay, sir.
Okay. So you should take multiple biopsies.
Okay, sir.
And the biopsy should be appropriate. Just taking a bit from one end is not that. It should be an appropriate biopsy.
Okay, sir.
One question here. What are the nasal masses which should not be biopsied? Which should not be or need not be biopsied? Should not be or need not be biopsied?
Sir, juvenile nasopharyngeal
Angiofibroma, number 1. Number 2?
Meningocele.
Meningocele, very good. If you suspect meningocele, don't biopsy. Number 3?
Meningoencephalocele.
Okay. Meningocele, encephalocele, just single one. Number 3?
Okay.
You're right.
Rhinosporidium.
Rhinosporidium, there's no need for biopsy because it is apparent.
Yes.
Anything else? No need to take a biopsy when?
When the diagnosis is apparent.
What? When you're in a routine practice.
Polyps, nasal polyps.
That's it. Bilateral polyps, not
Bilateral
unilateral. Not
polyps.
unilateral. Bilateral polyps. Actually, there's no need to take a biopsy. Okay.
Okay.
Suppose you are suspecting granulomatous disease. What is the precaution you should take on biopsy? Granulomatous disease like vaginous granulomatosis, example, vaginous granulomatosis, granulomatous lesions. What precautions you should take during biopsy? What happens in most of these granulomatous lesions? What is the crux? What is the pathology involved?
There is eosinophilic infiltration over the.
Majority of them, there is vasculitis. Vasculitis means inflammation of the blood vessels. Now, what is the precaution you will take during biopsy?
So bleeding has to be, we should expect.
Already this patient is having that. What? Suppose you have a lesion on the septum. If you are taking biopsy from both sides of the septum, what can happen if there is vasculitis?
A septal perforation can happen.
That's it. If you're suspecting a chronic granulomatous disease, don't take a simultaneous biopsy from both sides of the nasal septum. Get the point?
Okay, sir. Okay.
So that is the importance. Okay. Now the biopsy is reported as inverted papilloma. What will you do?
So patient has to be planned for surgery, sir.
What is the CT scan finding this patient? CT finding is the
you can put the CT scan, Anjana, and read the CT scan.
Oh, CT on, okay.
So this for the coronal thread, sir.
You can describe that.
Sir, it was a coronal CT. So it shows a mass that is filling the left nasal, soft tissue opacification that fills the left nasal cavity. Moving downwards, it was seen eroding the septum and extending to the opposite nostril, and it was eroding the roof of the nasal cavity.
Can we zoom it a little? Zoom change a little.
So going posteriorly, it was seen eroding the lamina papracia roof, the roof of the frontal sinus. And there was polypodal changes, polypodal mucosal changes in the left maxillary sinus also. And we can see a soft tissue.
It is eroding the roof of the ethmoids, isn't it? If I am right.
Yes, sir. Yes, sir.
It is producing extensive skull base erosion, is it?
Yes, sir.
Okay, anteroposteriorly. You have seen the CT scan earlier, huh?
Yes, sir.
then why did you proceed with the diagnosis of benign and surprised? Already biopsy has been taken, is it?
Yes, sir.
Okay, that's a reason. Okay, so there is extensive erosion of the base of skull. There is erosion of the orbit here.
Yes, sir.
And what about the posterior? What is just show the axial cuts? What about the posterior wall of frontal sinus?
So outer table and inner table both were eroded, sir.
Both are eroded. That's it. Okay.
Yes, sir.
What is the
Any
report? What is the
radiology
radiology report?
Sir, I haven't put the photo of the reports.
No. I don't need the photo. What has the radiologist commented? I have seen the film. What has the radiologist commented?
So that is a soft tissue opacification with multiple calcific focus. And there was erosion of the lateral wall, ethmoidal sinus, supramedial aspect of the orbit, lamina papracia, and the soft tissue density, a soft tissue component was involving the preseptal compartment and periorbital soft tissue.
And what was his diagnosis?
Actually, they gave the diagnosis as fungal sinusitis, sir.
Okay, right. So obviously, this should be a malignant lesion. Okay, obviously.
Yes. Yes.
When your diagnosis points to a malignant lesion. Okay.
Okay.
MRI, I put the MRI also.
So MRI undo.
Anjana, have you?
Sir.
Just describe the MRI.
Sir.
What is this? Which MRI is that? T1 or T2?
It's a T1 weighted, sir.
T1 weighted image. Then what? What are you seeing?
T1 weighted image that shows the variegated appearance of the lesion, the right nasal cavity with extension onto the maxillary sinus, filling the ethmoids.
You should say that's a hyperintense lesion. Okay, there is a slightly hyperintense lesion in comparison with the inside the nose maxillary sinus ethmoids, which is extending onto the intracranial cavity with no extension into the brain. It's not involving the brain, isn't it? What about dura?
Sir, dura was intact. There was a hyperintensity of the dura was present. Dura had an enhancement.
Enhancement, okay.
Yes, sir. Dural enhancement was present. It had a mass effect on the anterior cranial fossa, but dura was not breached.
Okay. Okay, your report was inverted papilloma. What did you do? Your biopsy report was malignancy. What did you do?
So, the biopsy report was inverted papilloma. Then, considering the extensive involvement of the lesion, combined approach has to be taken. That is endoscopic plus open approach.
So, what will you do? What are you going to do? Just tell me.
So, transnasal endoscopic approach with
even if it is malignancy, I think your treatment doesn't change.
Yes,
it is almost the same. Why? Because it's a slow growing malignancy. Yes, treatment is almost the same. So what surgery are you planning to do?
Sir, draft procedure along with open procedure, that osteoplastic flap repair can be done for the patient. Sir.
So tell me the reason for doing an osteoplastic flap and tell me the reason or pitfall of doing an osteoplastic flap in this case and the rationale of doing a draft here.
Sir, because of frontal sinuses, frontal and ethmoid sinuses are fully involved. A draft 3 can only clear the disease from the frontal sinus.
Agreed.
And
what's the pitfall of osteoplastic flap here since you brought up the topic?
Sir, osteoplastic flap repair with obliteration would impair the flow.
How do you do an osteoplastic flap?
Sir, either a bicoronal or eyebrow incision can be put and
You already
enumetate.
told. You already told there is erosion of the anterior wall, isn't it? I asked
Yes,
you
sir.
specifically earlier. Then how
Yes.
are you going to do an osteoplastic flap here?
Yes, sir. Our bone is eroded.
You only told me. And now you're planning for osteoplastic flap. How? So what are the other procedures on the frontal sinus other than osteoplastic flap? External procedures.
Frontal sinus trephination.
You don't do that here. Anything else?
Yes. Cranialization.
Cranialization, you don't do this. That is for the posterior table.
Okay.
Not the anterior table. So what is the procedure known as?
Riedl's procedure.
This is not Riedl's procedure. Slightly difficult here. Patient is going to have a defect there.
Yes, sir.
And what about the enhancement on the dura?
It could be the dural involvement or the edema of the dura.
If you want to encompass the entire lesions together, where there is involvement of the anterior table of the frontal sinus, posterior table of the frontal sinus, involvement of the ethmoids, involvement of the maxilla and nasal cavity, partly max, I don't know, involvement of the nasal cavity, maybe maxilla.
Okay.
All together, you want to encompass with one single surgery. Is there a single surgery? And then there is enhancement of the dura as well.
Lateral rhinotomy with
lateral rhinotomy with incision. One incision is lateral rhinotomy. Agreed. Anything else? Would you extend incision upwards? Lateral rhinotomy incision.
Yes, sir.
And do what?
A bifrontal craniotomy can be done.
You do a craniofacial resection. Okay, here.
Sir. Okay.
If the dura is involved, that means you will have to sacrifice the dura. It depends. You have to get a combined surgical procedure.
Okay.
You've taken a biopsy already. Biopsy edutana, Kiran?
Inverted papilloma.
Inverted papilloma.
But it was not a representative biopsy, I think.
This is operated.
So we have explored, we have taken by the end result was HP was malignancy.
That's it. So clinical diagnosis has to be malignancy. Possibly multiple biopsy.
It was inverted papilloma with areas of malignancy.
Okay. Dural involvement. Surgery, there was dural involvement?
Dura was not involved, but dura was exposed. Posterior table was fully eroded. Dr. Krishnan operated. He was managed to remove it from the dura and from the sinuses. He combined a draft with an external. He did a lateral rhinotomy with frontal extension. Through that, he removed some part of the tumor left through the nose by doing a draft. And the dura was posterior table was eroded and dura was exposed there, but there was no actual involvement of the dura.
Okay. Anyway, that's it. Jude, what else to ask? Anything else to ask, Jude?
No, sir.
I think slightly difficult case for examination, slightly confusing, difficult, but it is straightforward in the sense it has to be the diagnosis has to be malignancy rather than benign lesion.
Yes, sir.
It should be a long-standing benign lesion which is turning malignant. That should be the diagnosis. I think we can get inputs from other examiners in the audience.
Any comments from other?
Aniraja, any other examiner in the audience?
What about the orbit? What about the orbit?
The medial wall of the orbit was eroded, and even the periosteum was it is involved through the periosteum. But he was able to remove the tumor. The muscles were exposed, but he was able to remove the tumor without much injury to the muscles.
But
So it has gone into the
involvement of
yeah.
the
There was
orbital is a indication
just
for
beyond
the
just gone into the periosteum, beyond the periosteum.
But as such, patient doesn't have any limitations of movement, Lazar.
If the biopsy came as a malignancy, is the involvement of the orbital periosteum, is it orbital extension is needed, isn't it?
Yeah, actually, we send the patient to RCC for further whether it can further be managed by CT chemo radiation.
It's a big, patient has a big problem. You know what the problem is? If the patient needs to undergo radiation, again, vision will be compromised. The big problem.
And neuro is also exposed. So you might have
can have all issues there.
All issues there. So they are just evaluating the patient in RCC. You know, what the plan is, we've not come to know yet. Whether they are planning radiotherapy or just going to give chemo, no idea.
So if this is going to be a pure inverted papilloma, what will be the management without any malignant transformation, or what will be the ideal management for inverted papilloma?
Surgical management, sir, craniofacial resection. Same.
Any other example?
So what you have?
Shanti, anything else to add? You are in Ghana,
I don't think so. I think everything was very nicely covered in the short period of time.
Jude, anything else to add?
In inverted papilloma, any staging?
Yeah. Just tell something about inverted papilloma. Finish off.
What are the different names, etc.? Anjana?
That?
Staging of
inverted papilloma. What are the etiology?
So different names of inverted papilloma, Ringer's tumor, transitional cell papilloma.
Then
other names?
What are the different types of sinonasal papillomas? How will you classify that as per the WHO, latest WHO classification?
Schneiderian papilloma, that is exophytic, cylindrical, and inverted papilloma.
Yeah, inverted, exophytic, and oncocytic. That is the three types. Okay, those are three types.
Okay.
Then
those are the three types of papilloma.
Site of origin.
Site of origin, inverted papilloma is most commonly from the lateral wall. Cylindrical
Most
type.
commonly
Oncocytic is also from the lateral wall.
What about exophytic?
That is from the medial wall. Septum is the most common.
Exophytic is in the septum. Okay. Then what else? What is a peculiar characteristic of inverted papilloma? It can be multifocal, right in the Schneiderian membrane. Anywhere it can be seen multifocal. Then we talked about coexisting malignancy. We talked about metachronous malignancy.
Recurrence.
Recurrence is an issue nowadays. Okay.
Okay.
The radiological findings in inverted papilloma. Specifically, you told about MRI. MRI is your cerebriform, contributed cerebriform pattern. What about CT scan specifically? Finding?
Focal hyperostosis of the bone at the region of attachment can be seen.
Very good. So hyperostosis and calcifications can be seen.
Okay.
Importance of hyperostosis?
That specifies the attachment of the lesion, and the tumor can penetrate into the bone at the sites of this hyperostosis, and they have to be drilled out during surgery.
So subperiosteal dissection. You have to go beneath the periosteum. You have to drill out the bone. That is the importance of the site of origin of inverted papilloma. Okay. Then what is the classification? Already Jude sir asked you. What's the classification of inverted papilloma?
Krauss classification, where stage 1 is the tumor confined to the nasal cavity. Stage 2 is a tumor involving the nasal cavity and paranasal sinuses, which includes a maxillary sinus. If the stage 3 is a tumor involving the frontal sphenoid, nasal cavity, maxillary, frontal, and sphenoid complex. And stage 4 is if the tumor has got intraorbital, intracranial, and extension.
So if it is inverted papilloma, here in this case, what should be the stage?
Stage 4, sir.
Stage 4. What are the malignancies common in inverted papilloma?
Squamous cell carcinoma is the most common malignancy associated
Other
with
malignancies. Other malignancies.
adenoid cystic carcinoma.
Not adenoid cystic, adenocarcinoma and verrucous carcinoma. Verrucous
okay.
carcinoma.
Okay.
Even mucoepidermoid has been reported. Okay.
Okay, sir.
Right. One point. If it is olfactory neuroblastoma, I'm just finishing it up. Okay.
Okay,
What
sir.
are IHC markers in olfactory neuroblastoma? PG question.
Cytokeratin.
No.
Sorry,
No.
sir. S100 neuron specific enolase S100 and
Synaptophysin. Okay.
okay, synaptophysin.
Synaptophysin.
Okay.
What is the specific peculiarity of olfactory neuroblastoma? It is unique for that in nasal cavity. Unlike other tumors of nasal cavity, olfactory neuroblastoma, what?
The single vascular polyp.
More importantly,
Maybe it's a turbinating appearance.
it arises from the neural crust. If it arises from the neural crust, what can happen? What else? Lot of paraneoplastic syndromes have been described in olfactory neuroblastoma. That means that this particular tumor, in some cases, can secrete
catecholamines.
Not catecholamines, something else. Can secrete hormones. Okay, secrete hormones like ACTH and antidiuretic hormone. That means that these patients can have SIADH, syndrome of inappropriate ADH secretion.
Okay, sir.
Now, these are all PG topics, PG discussion. So you should know this. And this should be there in your answer paper when you're writing your answer. Okay.
Okay, sir. Okay.
So my evaluation about Anjana, I'm slightly honest. So I don't think I'll always say the positive first. The positive first is you sat through the entire session, and you are not. In fact, you are not taken down up by the questions. You got a lot of questions, but you face the questions with what so-called maturity. Okay.
Okay, thank you.
But some basic points, I think you are lacking. You have to improve upon the basics. In PG level, you should always know the basics. If you go wrong in basics in your explanation, it is a big negative. Advanced topic, it is excusable, but basic topics you should never go wrong. Okay, it's not going wrong. You should know that. I think you know major. I have to prompt you. You should not wait for the examiner to prompt you. You should answer immediately. Okay.
Okay.
Maybe you know that you have read that it is not there in your mind. So that's important. So that is feedback. Okay. I don't think you were a bad candidate here. I think you sat through the entire questions very well. Jude?
Management and nice decision.
We'll finish it, sir.
Yeah. Yes, Kiran.
Thank you, sir. Thank Dr. Shibu, sir, Professor of Proto Medical College, for beautifully asking all these questions. And I also thank Dr. Jude, sir, also for conducting this examination. Thank Nishant also for coordinating and conducting.
Thank you, sir.
Thank you. Okay, Anjana. Okay. Jude, good night.
Thank you.
Good night. Good night.
Good night. Kiran, good night. Nishant, good night.
Good night. Good night.
Good night.